We cannot offer certificates of attendance for videos you have viewed. Unfortunately, you must participate in our education live. First, up in our 4-month series on what matters, we will be talking about what is palliative care. It gives me great pleasure to introduce today's speaker. Dr. Marita is a hospice and palliative medicine physician. She has a broad breadth of experience in a variety of clinical and educational settings in Southern California, Miami, and Hawaii. Prior to joining Hui Pohala, she was most recently at St. Francis Hospice as the medical director. Previous positions include primary care internal medicine with Southern California Kaiser, Orange County, and at Kaiser, Hawaii. At Kaiser, Hawaii, she was also a hospitalist, section chief, and created an outpatient palliative care consultation service. While with the University of Miami, AHEC, Area Health Education Center, she mentored medical students and residents, nurses, and physician assistants while caring for indigent populations in various settings, including the houseless, and worked in clinics and inpatient wards for persons with HIV and AIDS. While in Miami, many years before palliative medicine became an entity, she realized that her role as a physician was to help the living to live better, including helping the seriously ill and those who were dying to live as well as they could. She is an assistant clinical professor of medicine at the University of Hawaii, John A. Burns School of Medicine, Department of Geriatric Medicine. Dr. Marita's focus is healthcare workforce development and palliative care. She recently created a curriculum for introduction to palliative care for allied healthcare workers. Take it away, Dr. Marita. Welcome to the Echo.
All right. Thank you. Hi, everyone. Good afternoon. Thanks for zooming in. I hope that you've all rested after your siesta. Yeah, right. You wish, right? You wish you had a siesta. I know that you've all been working really hard, providing essential care to your clients and patients, and which is very much appreciated. I want to thank Dr. Fernandez and Ms. Ibrao for inviting me to speak to you about the introduction to health care for allied healthcare workers. This is the first session of a 2-part curriculum that I and 2 valued colleagues had created to include into the education of allied healthcare workers, including community health workers and EMTs and etc. I hope that the learnings from today will be helpful for you in your work as well. And right now, I will shamelessly self-promote that I have been facilitating with the Department of Education and the University of Hawaii system to provide the EMT courses and expanding the CHW courses to high school students, the seniors, so that when they graduate high school, after taking these courses, they can have certifications as EMTs or a certificate as a CHW and have early onboarding into the healthcare workforce. This will help the healthcare facilities and organizations, and most importantly, will help to increase access to high quality palliative care to our people who are living with serious illness. I hope that you will be seeing more of these people, these professionals working and as part of the healthcare teams of your clients and patients. Okay, and before I get into the meat of this discussion, I want to give a shout out to my daughter, Heidi, who is zooming in from Washington, D.C. So hi there, my dear. Okay, so I will go ahead and get started. I'm going to share a screen, okay? Alrighty then, are you guys all able to see that? Yes, okay. All right. I'm going to go ahead and turn it into a slideshow. And this talk is generally a interactive course. So normally I'll ask the audience a lot of questions. And given the interest of time limitation, I'm going to make it just partially interactive. But I want to ask the group, and I want you to all know too that even at this stage, a lot of my physician colleagues are uncertain about what palliative care is. So I want to see what you folks, I mean, because I'm sure all of you or most of you have heard of palliative care before. And so maybe some of you could shout out or put in the chat box as to what do you think palliative care is?
Supportive care prior to hospice.
Okay. Anything else? Anybody else? All answers welcome. All right, I guess we have a lot of shy people. In any case, hold that thought and let's go ahead and see. Okay? Again, I'm the presenting faculty, and these are my two valued colleagues. Dr. Dan Weiss and Dr. Sandy Borget Henry have doctorates in nurse practice, and they're on faculty at the Chaminade University. They were invaluable in editing this PowerPoint. So I just want to thank them for that. What are the learning objectives? The elements of palliative care. Describe palliative care and how it compares with usual disease-modifying care and hospice care. Explain who may benefit from palliative care and how it can benefit them. Understand the role of CHWs and EMTs and other healthcare workers, allied healthcare workers as members of the PC team. And understand the dynamics of communication among the team members. Dr. Timothy Ehrig is a physician at Harvard, and he describes this so eloquently that I didn't feel like I needed to reinvent the talk. But I'm just going to show a short clip of one of his talks. And in the beginning, there may be some commercials, so we'll have to bear with that.
Dr. Morita, we cannot hear the video.
Were you folks able to see the video?
No, we didn't.
Oh, no. Ah, Do you want me to play it again so you can see it, or I can try on the next video? What do you think?
Dr. Fernandez, what would you like her to do?
Maybe we can get John's assistant.
Well,
Sorry,
oh,
maybe
you know
we
what
can
I
get
can,
John's assistants to play the video.
okay, you know what I can do? What I can do is, hold on, I'm gonna stop this share and go back to the, hold on, I'll go ahead and pick out that video. Can you see that now?
We can only see the slide, not the video.
No,
Can you see the video now? Can you see the video now?
No.
no.
Oh, gee,
Is this from YouTube, Dr. Marita?
yes, that's the link.
You want to try email me the link and I can try.
Okay, the link is the one that's on the,
Oh, I see. Let me see if I can get it on from my.
yeah. Okay, hold
Okay.
on for a moment.
John, I also put it in the chat for you.
Okay.
I apologize for that hiccup. And John, I want to run it, thank you, John. I run it from 11 seconds to 2 minutes and 44 seconds. 2 minutes and 44 minutes. 2 minutes, 44 seconds, yeah. Then I'll be having another one a little later.
Sorry, you said you wanted to run it from 2 minutes and 44?
I want to run this from 11 seconds
Okay,
to 2
hold on.
minutes and 44 seconds.
Okay, hold on.
And at 2:44, just stop it, and then we'll resume the PowerPoint.
Okay.
And I would like to talk to you today about healthcare. I'd like to talk to you about the health and care of the most vulnerable population in our country, those people dealing with the most complex, serious health issues. I'd like to talk to you about economics as well. And the intersection of these two should scare the hell out of you. It scares the hell out of me. I'd also like to talk to you about palliative medicine, a paradigm of care for this population, grounded in what they value, patient-centric care based on their values that helps this population live better and longer. It's a care model that tells the truth and engages one-on-one and meets people where they're at. I'd like to start by telling a story of my very first patient. It was my first day as a physician with a long white coat, and I stumbled into the hospital, and right away there was a gentleman, Harold, 68 years old, came to the emergency department. He had had headaches for about 6 weeks. It got worse and worse and worse and worse and worse. The evaluation revealed he had cancer that had spread to his brain. The attending physician directed me to go share with Harold and his family the diagnosis, the prognosis, and options of care. Being 5 hours into my new career, I did the only thing I knew how. I walked in, sat down, took Harold's hand, took his wife's hand, and just breathed. He said, "It's not good news, is it, Sonny?" I said, "No." And so we talked, and we listened, we shared. And after a while, I said, "Harold, what is it that has meaning to you? What is it that you hold sacred? And he said, my family. I said, what do you want to do? He slapped me on the knee. He said, I want to go fishing. I said, that I know how to do. Harold went fishing the next day. He died a week later. As I've gone through my training and my career, I think back to Harold, and I think that this is a conversation that happens far too infrequently. And it's a conversation that has led us to crisis. The biggest threat to the American way of life today, which is healthcare expenditures.
Or we can stop it
What
there
do
now.
we know? We know that this population.
John, yeah, thank you. All right. So I'm going to go back to sharing my screen. Hold on. Sorry about this challenge with this technology here. Okay, I'm going to go back to my oh, heavens. Sorry about that. Okay. So palliative care is specialized medical care for people living with serious illness. It's focused on providing relief from the symptoms and stressors of illness. It's based on need, not prognosis, also known as estimated length of life, and is appropriate for any age and any stage of serious illness. It's an extra layer of support for people living with serious illness and the people caring for them. It's provided in addition to usual disease-modifying care, and the focus of care is guided by the individual's beliefs, values, and wishes. It's facilitated by professionals and caregivers using informed and shared decision-making. And as Dr. Eric Bayok, one of the luminaries in palliative care, had written a book, It's the Best Care Possible. Also by one of the luminaries in palliative care, Dr. Pantalat, It's living as well as you can for as long as you can. So who are part of the team? Who are the team members on the palliative care team? Physicians. We're fortunate we have nurse practitioners, nurses are essential, social workers, and chaplains. And allied healthcare workers will certainly enhance the team. Okay, another video. So John, I'm going to need help with you from you again on this one. It's the same video from 6 minutes and 20 seconds to 11 minutes.
Can I get the link in the chat? And then
Yeah, it's on that same, okay.
or is
let's
is it the same one?
It's the same video. Yeah, and you
Okay,
just have to
okay.
move it along.
Oh,
Yeah.
okay, okay.
So I guess I'll have to stop my share, yeah? John, do I stop my share now?
Yeah, Dr. Morita, stop. You can stop sharing. And John, please click the box of share computer sound.
Six minutes, 20 seconds. Yeah, and end at 11 minutes.
Be a digital detective. Enroll in the new Google Cybersecurity Certificate to jumpstart your
Group, Palliative Care in 2012, working with the sickest of the sick. Cancer, heart disease, lung disease, renal disease, dementia. How did we improve patient experience? I want to be at home, doc. Okay, we bring the care to you. Quality of life enhanced. Talk about the human being. 2, population health. How do we look at this population differently and engage with them at a different level, a deeper level, connect to a broader sense of the human condition than my own? How do we manage this group? So out of our outpatient population, 94% in 2012 never had to go to the hospital. Not because they couldn't, but they didn't have to. We brought the care to them. We maintained their value, their quality. Number 3, per capita expenditures. This population that today is $2.3 trillion and in 20 years is 60% of the GDP, we reduced healthcare expenditures by nearly 70%. They got more of what they wanted based on their values, lived better, and are living longer for 2/3 less money. While Harold's time was limited, palliative care's is not. Palliative care is a paradigm from diagnosis through the end of life. It could be hours, weeks, months, years, across a continuum, with treatment, without treatment. Meet Christine. Stage 3 cervical cancer, so metastatic cancer that started in her cervix, spread throughout her body. She's in her 50s and she is living. So this is not about end of life. This is about life. This is not just about the elderly. This is about people. This is Richard, end-stage lung disease. Richard, what is it that you hold sacred? My kids, my wife, and my Harley. All right. I can't drive you around on it because I can barely pedal a bicycle, but let's see what we can do. Richard came to me, and he was in rough shape. He had this little voice talking to him that maybe his time was weeks to months. And then we just talked, and I listened, and I tried to hear. Big difference. Use these in proportion to this. I said, all right, let's take it one day at a time like we do in every other chapter of our life. And we have met Richard where Richard's at day to day. And it's a phone call or 2 a week. But he's thriving in the context of end-stage lung disease. Now, palliative medicine is not just for the elderly. It is not just for the middle-aged. It is for everyone. Meet my friend Jonathan. You have the honor and pleasure of Jonathan and his father joining us here today. Jonathan is in his 20s, and I met him several years ago. He was dealing with metastatic testicular cancer. It spread to his brain. He had a stroke. He had brain surgery, radiation, chemotherapy. Upon meeting him and his family, he was a couple of weeks away from a bone marrow transplant, and in listening and engaging, they said, help us understand what is cancer. How do we get this far without understanding what we're dealing with? How do we get this far without empowering somebody to know what it is they're dealing with, and then taking that next step and engaging in who they are as human beings to know if that is what we should do? Lord knows we can do any kind of thing to you, but should we? But don't take my word for it. All the evidence that is related to palliative care these days demonstrates with absolute certainty people live better and they live longer. A seminal article out of the New England Journal of Medicine in 2010.
Okay, we can stop it now. Thank you, John.
Study
All
done
right,
at
I'm gonna go
Harvard.
back. Oh. So I want to go ahead and share my screen again. So talking about this palliative care and hospice. Hospice is a subset of palliative care. So they both have symptom management, palliative care for a life-threatening or life-limiting illness. With hospice care, it's for the end of life. So that's the difference. Another schematic. All hospice is palliative care, but not all palliative care is hospice. And we can take a look at this. So what do they have in common between palliative services and hospice services? Comfort care, reduction of stress, offer complex symptom relief related to serious illness, and physical and psychosocial relief. The difference is palliative care is paid by insurance or by themselves. Hospice services are paid by some sort of insurance, either Medicare, Medicaid, or private insurance. Palliative service can be provided at any stage of disease, whereas with hospice services, as deemed by Medicare, when the prognosis is 6 months or less, i.e., when the patient's expected length of life is 6 months or less, that's when hospice services can be provided. Palliative services can be provided at the same time as curative treatment, whereas curative treatment in a hospice level patient is deemed to be not beneficial. And with palliative services, it typically happens in hospitals, although you've probably seen a lot now lately. There's a lot of outpatient and home-based palliative care being provided through the different agencies, and we'll talk about that. And for hospice care, it's provided wherever a patient considers home. So that can be their usual home, a care home, a long-term care facility, adult residential facilities, and even houseless. The main thing is that we can contact the patient and find them, get a hold of them, and that they have adequate caregiving support. So palliative care improves quality of life. It makes illness more manageable. It focuses on seriously ill patients, and it's not necessarily at the end of life, which is different than hospice. Treatment focuses on 3 areas: symptom management, complex decision-making, and planning for the future care based on the patient's wishes. So where can this care be obtained in the state of Hawaii? And there's these terms that you've heard being tossed around: concurrent care, supportive care. Concurrent care and supportive care are the names that private insurance companies or insurance companies call their outpatient palliative care programs. So again, let me repeat that. Concurrent care and supportive care are names that the VA, that these different insurance companies call their outpatient palliative care programs. So the VA, Veterans Affairs, University Health Alliance, concurrent care. HMSA has supportive care. So I know it caused a lot of confusion. I love concurrent care because with the UHA particularly, there's no time limit and any diagnosis can be entered. A person can enter for any diagnosis. With the VA, that's how they started. And then they kind of streamlined it to a few diagnoses. And then now I think they're relaxing it a little bit more. HMSA has a 90-day benefit in a 365-day period, meaning if a patient starts their care on July 1st, it'll be good until June 30 of the next year. 90 days could be utilized. So how does that work? They come in for their condition, they have a certain concern, pain management, for example, or some kind of symptom management. And the benefit is once those symptoms are well managed, if they're well managed enough, then and the patient is stable, they can save those days. They can bank their days for a later time within that 365-day period so that it can be utilized when the need is there again. So that's one thing, but still 90 days. And the diagnoses are limited to 4 things: cancer, COPD, which is chronic obstructive pulmonary disease, also known as emphysema, which is irreversible airway blockage or obstruction. It doesn't stretch as much as well as a normal. And congestive heart failure of any kind, meaning a weak heart, a heart that pumps very weakly or poorly. So how do these organizations and people provide or improve the quality of care? It's really about the conversations. And the conversations are difficult. They are uncomfortable, but practice makes us better, doesn't it? So I want you to think about practicing these things. And the more you practice, we get better. So discuss the options available for care to the patients and their caregivers and their loved ones. It's important to understand the difference between palliative care and hospice, as noted in the slides before, and give the patients more control over their care with earlier advanced care planning conversations. And how can patients have control over their care decisions? Start the conversations early about their condition and their care options and possible outcomes. Now, sometimes you're going to run across patients who don't want to hear about their condition. They don't want to make decisions. So how do we handle that? How we do it is we say, Mr. X or Mrs. Y, we know that you don't want to hear about your condition. So who would you like us to speak to about your condition? And if you don't want to make the decision, who would you like us to talk to so that person can make the decisions? So that's a way to get around it, yeah? We want to equip patients with tools to help them make those care decisions. You can look up the Conversation Project or the Kukua Mau website for different tools and put their healthcare wishes in writing early. You guys have heard about advanced directives and polls, right? Probably over and over and over. So I won't have to go through that. So advanced care directives and polls, provider orders for life-sustaining treatment. I think about the polls as the advanced directives for paramedics. In case someone calls 911, we really want to have those documents available, those bright green documents, or it could be photocopy, but available so that the paramedics can see them and follow the wishes of the patients. If they're hidden away in some nice file or all over in some messy table and they can't find it, then the paramedics are going to do everything possible to resuscitate the patient, although the patient may not really wish to have that done. So just keep those things in mind, have it available. I'm not going to go over these slides very much, but it's just a reminder about how allied healthcare workers, including congestive CHWs and EMTs, can participate in care teams caring for our patients, our seriously ill patients in the future. The role of each member of the team. So you can see from this slide that for the various domains of suffering, that the multiple different disciplines can participate in supporting the patients. So in terms of medical conditions, disease modifying, that is the realm of the physician. If there are any physical concerns, pain, symptom, any kind of symptom, pain, nausea, shortness of breath, the physician assesses the patient, helps determine what may be the cause, and determines what are patients' care options or therapeutic options. And the rest of the team, nurses, EMTs, social workers, etc., can help support that process, support the patients and reminding them what's available to them, and then encourage them to follow through. If there are social support questions, financial queries, and how about, quite a lot of times patients have concerns about where they're going to live. We think about the social worker as the first person to help with that. Community health workers can do that. Of course, everybody on the rest of the team can help with the solutions, physicians, nurses, etc. If there are emotional concerns regarding fear, anxiety, depression, whatever else, again, we think about social worker, community health worker, chaplaincies, and definitely physicians should participate in that, and as well as nurses. And then the spiritual concerns. Why me? Am I being punished? Did I do something wrong that I'm being punished with this condition? And then the suffering soul is a person who feels that they deserve to be punished for something and are oftentimes resistant to all kinds of therapeutic options. And the chaplaincy can help with that, social worker, and the rest of the team. Again, the physician should always participate with that too, along with the nurse and community health workers. Dynamics of communication within a healthcare team. Patients are discussed in interdisciplinary team meetings. So the patient's name, their condition, what are the concerns, what are the questions, what are the potential solutions are discussed, and how can we, integrate into their care. So what are the 5 C's of the consultation model? That's really important for us in caring for a patient. Again, communication, conversation is so essential. First, we want to contact the person. If a patient has a concern, we want to contact the person who would be the one that would take care of that problem. So if it's a a medical problem, we call the doctor. If it's a housing problem, we call the social worker, etc. Then we want to communicate to that person or those entities, what is the situation? And then ask the core question, how can we help that patient? What are the potential solutions? And amongst the team members, we collaborate about what are the possibilities in helping this patient. And then close the loop in two ways. You present the options for therapy or care to the patient and their loved ones, and allow them to make their choice. And also loop back to the rest of the team in terms of what the patient and family have been informed of and what they've chosen in terms of the choices, and then be sure to follow up that the goals of the patients are being achieved. There are 5 keys to effective communication. Choose your words wisely. I want to tell you about a real life case that I heard a few days ago. And I want you guys to think about that. I heard a caregiver suddenly yell at a client. Stop rubbing your eyes. Stop rubbing your eyes. I said, stop rubbing your eyes. Stop rubbing your eyes. What do you think about that? Anybody want to say?
It could have been said nicer.
Right. So choose your words wisely. That was a little rough, right? It was really verbally abusive. And that caregiver did not give the client or patient an opportunity to explain why he or she was uncomfortable and thus rubbing the eyes. And therefore, it precluded any kind of solution for the patient or a way to relieve the discomfort. And given the tone of the caregiver, I would think that one would be afraid to then speak or share our concern. So consider your tone, inflection, and body language, and listen to what others say. Write less, say more, and know when to stop. And on that note, I'm going to stop. Questions? I know we ran over. I apologize for the IT challenges.
Thank you, Dr. Morita, for such a beautiful explanation. You gave us a real 360 view of palliative care from all the team players, and those TED Talks was very powerful. Thank you for sharing those videos with us.
Thank you. I hope that some of the learnings can be utilized in your work, and that could be helpful. Any questions?
Will the slides be made available to us?
Yes.
Great. Thank you.
Anything else?
Could you tell us how you approach a family who you're trying to get them to complete the post or the advanced directive, and they say next time, or they do half the form, and then it's never get completed? What strategy do you have to work with families where we are struggling with these documents?
Okay. So I guess it depends on the situation, but I might try and say, hey, hey, has that advanced directive been completed or the polls? And they say no. I'll say, well, I'll tell you what, I mean, it's really important to us. It's really important to us that we know what's important to you. We want to know what's important to you so that when a situation arises, that we can take care of you in the way that you want to be taken care of, in a way that's important to you. So these documents will help us learn about you and know what your choices are. And so what do you think about, what are your concerns about completing the form? And then we can hear what they have to say. That's the way I guess I would lead off on it. Anything else that you might suggest, Dr. Fernandez?
I like your sentence. It's important for us to know what's important for you. That is a beautiful way to put it.
Any other questions?
What if it's a totally different situation and it's actually the family members or the POA that has to go ahead and complete the pulse because the pulse wasn't completed prior to the person getting demented? How would you handle that? Because sometimes, the families are not on the same page. So one wants, and there's different powers of attorney. So one wants to sign the DNR, another one doesn't. How do you handle that?
Yeah, I think those are really challenging and happens unfortunately infrequently. I guess we could do a family meeting. Family meeting would be best, then you can hear all the different people speaking within a group rather than individual conversations. But I think it would be important to know what those individual people are worried about. What are they concerned about, right? About maybe filling out DNR, or what are they concerned about doing full code or whatever. So we want to hear about their concerns first and then go from there. Does that make sense?
Yes. One of the questions I always ask is, did you ever have this conversation with mom? Do you know what mom's wishes were? Would she want to be, if she was in this state or cognitive position, would she want to be resuscitated or not? So I always bring that if there's any history of the conversation.
Absolutely. You're exactly correct, Gwinnett. That is the most important. And unfortunately, even if some of these folks have heard the conversation, and one of the things I always talk about when completing one's advanced directives, to be sure that when you select a durable power of attorney, that power of attorney will follow your wishes, even if he or she does not agree with you. I think that's really key, right?
Right.
Yeah. So then now there's no durable power, there's no advanced directive, and now you have different voices with different opinions. And so you go back to what the mother wants, and they may still dissent. And I've had many of those conversations. Usually it takes over an hour to talk it through, just hearing their concerns, trying to put themselves, would your mother want, or what do you think your mother would want if she was in this situation? Hopefully they can put their feet into that situation. If not, then I say, well, what about you? If you were in this situation, what would you want for yourself? Trust trying to build on the empathy portion, but it is very difficult. Again, uncomfortable, difficult. Again, every time I've had a Discord, it took over an hour to get these things settled down.
Thank you
But
so much.
hearing from them.
Thank
What
you
was
for
that?
the time. Thank you for the time you spend with the families. It's not an easy job. Thank you, Dr. Morita.
Yeah, well, we all know that, right, Rita? Dr. Fernandez.
There's a question that is coming to us in the chat from
Okay.
Lolita Ching, and I'm so happy we are having the RN case managers join us for these care home echo sessions. So Lolita's question is, I need to know if the hospice palliative care team knows when a client is admitted to either foster home or expanded arch that there is a RN case manager.
Yeah, so whenever a patient is admitted to either service, palliative care or hospice, there always is a RN care manager, always.
Not from the hospice side, whether they know that there is a community assigned, like Lolita is a case manager in the community. She doesn't work for a hospice. They are case managed because it's a requirement from DHS that every patient gets case managed. So all, especially patients in foster home, they have case managers. So does the hospice team work with the team on the outside? Do they collaborate with the community case management team?
Now, I cannot speak for other hospices, and I stepped down as a hospice manager from medical director 2 years ago from St. Francis, and certainly the social workers were always the one that we're always in touch. Social workers and RNs were always in touch with the care managers, and especially if there were any kind of questions, discords, or anything, any issue that arose, we always needed to go back with the care manager.
Okay, thank you. And Lolita,
Collaboration, right? Collaboration. So the case manager from the case management organization still are part of the team, right? Part of the collaboration.
yeah, so Lolita, I can speak for Bristol and Islands. Yes, when we know that when we have somebody from a care home or a foster home, that there is an outside case management agency we need to collaborate with, we need to make them aware what we are doing, we need to know what they are doing. And especially if we are looking at changing the placement, we have to collaborate with the case manager. Do you want to share any experience? Is there any case you want to highlight, Lolita? All right, there's technical difficulties on her end, but I'm so happy because we are inviting the case management agencies to these echoes. So I'm so pleased we have Lolita joining us. We also have Percy Ihara from Generations Magazine, who is here, and he thanks you for your lecture and says this information needs to be put out to the masses of seniors and their families. So
Thank you, Percy. I met again Percy at this Chefs for Hope benefit last week Friday, and we shared a table. So thank you, Percy, for attending, as I shamelessly promoted myself.
Great presentation, Dr. Marita and Dr. Fernandez. Appreciate it.
Thank you, Percy. Percy, why don't you tell people what you do? Go ahead.
Well, for those of you that don't know Generations Magazine, it's a resource magazine for seniors and their families. We've been doing it for 14 years now. And actually, Dr. Rita Bell Fernandez has written for the magazine. And I invite both of you onto my radio show that we tape on Fridays. So please let me know.
Love to do it, Percy.
More information, you can go to generations808.com. Has all our past radio shows and magazine issues. So thank you very much.
Thank you, Percy. Any other questions, concerns, cases?
So I've heard recently that durable power of attorneys have to be renewed every 5 years. Is that so true with durable power of attorney for healthcare decisions also?
I have not heard that. How about you, Dr. Fernandez?
I'm unaware of a 5-year requirement, sorry.
Yeah, I have not heard of that.
I know, ladies, that for real estate transactions, because I deal in lending, for the most part, a lot of them do not like to take older power of attorneys over 5 years. So that could be an issue, but I'd run it by your attorney.
Yeah, for healthcare, we don't have that limitation. But thank you. All right. Okay, anything else?
Okay, we can move on to the next slide, John. So is Lila joining us?
Hi, yes. This is Leila Vendor. I'm so sorry. My camera decided to stop working. So please remember to those that are attending that starting this month, please share with our team these questions. You know, does your client or clients have an advance directive? Do they have a healthcare power of attorney? Do your clients have a post? And if you have a case managers with the CCMA, they're a great resource to, go over this at their monthly visits. And also, of course, when you take your patients to the doctor. Okay, and just a reminder that evaluations are emailed out using an automatic system. So please double check the spelling of your names and email addresses. Otherwise, you might not receive the certificate. Thank you, everyone, for attending. And thank you, Dr. Morita, for that beautiful presentation.
Thank you. Thank you for attending. Yeah, appreciate that. Thank you. Hopefully it was helpful.
John, could you put the evaluation? Yes, the link is there by John to get your CME certificate. Please click on the link so you can fill out the evaluation for today's session.